I'm Lauren Hinke, and I'm joined by my co-host, Stephen Chun, for a special release of the Energy Oncology podcast that we are coordinating with the publication of the long-awaited NSABP B-51 trial for breast cancer in the New England Journal of Medicine. To break this all down for you, we are first speaking to the B-51 principal investigator and chair of the Energy Oncology Breast Cancer Core Committee, Dr. Terry Mamunas. In addition to his longstanding roles with the NSABP and NRG-Oncology, Dr. Mamunas is director of the breast program at Advent Health Cancer Institute and professor of surgery at the University of Central Florida College of Medicine.
Dr. Mamunas, congratulations on the publication of this landmark study in the New England Journal of Medicine. First off, to refresh everyone, NSABP B-51, also known as RTOG 1304, was for patients whose breast cancer has spread into their lymph nodes. This included all types of breast cancer, such as estrogen receptor positive tumors, human epidermal receptor 2 or HER2 positive tumors, and triple negative breast cancers not expressing any of the aforementioned markers. And in these patients, we've been increasingly seeing that systemic therapies given prior to surgery, like chemotherapy, hormone therapy, and targeted therapies, can fully eradicate the cancer from the lymph nodes in what pathologists call a complete pathologic response. For those of you unfamiliar, when we give an anti-cancer therapy prior to surgery, this is what you might hear us on the podcast call neoadjuvant therapy. Can you tell us how often we encounter this situation where a patient with lymph nodes positive from breast cancer, we give them neoadjuvant therapy, and we end up fully eradicating the cancer in those lymph nodes in what we call a complete pathologic response? And with the improvements in systemic therapy happening all the time, should we expect this situation to become ever more frequent in the future?
Yes, thank you very much, and that's a great question. So we actually started to notice this so-called downstaging of the axillary nodes in some of the early randomized trials comparing preoperative to postoperative chemotherapy, such as, for example, the NSABP B-18 trial. And in that trial with chemotherapy that we're using at the time, which is adriamycin and cyclophosphamide, for 4 cycles given either before surgery or after surgery, we noticed about a 30% downstaging of the axillary nodes. In other words, patients in the adjuvant therapy group versus those in the neoadjuvant therapy group, those in the neoadjuvant therapy group had about 30% less nodal positivity. That was like the first demonstration, one of the first demonstrations that you can not only shrink the tumor in the breast or make it go away, but you can do the same for involved axillary nodes. And then, of course, we did many neoadjuvant trials in patients that we knew that the nodes were positive because they were enlarged, and in fact, they were biopsied before neoadjuvant chemotherapy, so we knew that the nodes were positive, and then we went to surgery and saw the downstaging. So when we introduced the taxanes into neoadjuvant therapy, these pathologic response conversions went up to about 40%. And of course, since then, we've seen a significant increase in the conversion of positive nodes to negative nodes, but it's also dependent on the tumor subtype. We see the highest conversion for patients with HER2 positive breast cancer and triple negative breast cancer, less so in patients with hormone receptor positive HER2 negative breast cancer. The newer treatments that were introduced for triple negative, such as, for example, immunotherapy, pembrolizumab, or carboplatin added to the adriamycin, cyclophosphamide, and taxane schedule, we saw pathologic complete response rates in the axilla to be upwards of 65, almost 70%. The same was true for HER2 positive patients. Triple positive patients have almost about a 50% conversion, and hormone receptor negative HER2 positive patients have almost an 80% conversion. And those with hormone receptor positive HER2 negative disease, the conversion is expected to be between 15, 20, maybe 25%. So it's subtype dependent, but with new treatments that we have, this is a substantial proportion of patients in particular subtypes that actually convert the nodes from positive to negative.
That's really fantastic. So, as I understand it, the fundamental question being asked in NSABP B-51 was that for these patients whose tumor has disappeared from their lymph nodes with this neoadjuvant therapy, whether or not we need to be irradiating their regional lymph nodes, or if we should just be treating the site of the original tumor in the breast or chest wall. Why is this question important, and what was the impetus for doing this trial, NSABP B-51?
That's a great question. So the rationale behind this trial, first of all, is that the traditional approach of surgery first, followed by adjuvant therapy, including adjuvant radiation, was the way we did it for many years. And we have collected a lot of data and several overview analyses to show that for patients with positive nodes, when they present with positive nodes and have surgery, then the addition of adjuvant radiotherapy, either post-mastectomy radiotherapy to chest wall and regional lymph nodes, or after lumpectomy, breast radiotherapy and regional node radiotherapy to the lymph nodes, improved outcomes for these patients. There's clear evidence, and it did show if only 1 to 3 positive nodes are involved, or 4 or more positive nodes are involved. So that has been very well established. But at the same time, we did not see benefit for patients that had negative axillary nodes with surgery up front. So we knew that patients benefited if they were positive, and we knew that radiotherapy doesn't benefit patients if they presented as node negative and were operated. But then as we started to use more and more neoadjuvant chemotherapy, then we realized that we downstage patients from positive nodes to negative nodes. And there is not a lot of information to tell us whether these patients essentially clinically behave as node positive and they could benefit from radiotherapy because they were not positive or they presented, or maybe they don't benefit from radiotherapy because they're not negative at the time of surgery. Now, we do have evidence from studies that were prospective studies that retrospectively were analyzed, such as, for example, the NSABP B-18 and B-27 studies that were preoperative chemotherapy. B-18 was preoperative versus postoperative chemotherapy, and B-27 was preoperative AC or preoperative AC followed by docetaxel. And for those studies, we were able to do a combined analysis, and there's several other studies that actually showed similar things. So we did a combined analysis to see what are significant predictors of local regional recurrence to maybe guide our radiotherapy decision. And we found that essentially some clinical factors were significant predictors. For lumpectomy patients, was the age of the patient, was clinical nodal status being involved up front, but also, and for mastectomy patients, was clinical tumor size and presentation. But for both groups, what we also found was the combination of pathologic response in the breast and lymph nodes was also a significant predictor of local regional recurrence. In other words, even if you presented with positive nodes and you had high risk of local regional recurrence, if you converted your nodes to negative, and in addition, you have a pathologic response in the breast, in other words, there was no disease at all, that minimized your risk of local regional recurrence. So these observations, and ours and from other institutions such as MD Anderson, similar data, led us to hypothesize that maybe because these patients have much lower risk of local regional recurrence because they responded to the preoperative chemotherapy, perhaps they would not benefit from the addition of regional nodal radiation. In other words, they may behave more like node-negative patients because they were node-negative at surgery and not like node-positive patients as they were when they presented. So that formed the main rationale for the conduct of this study.
So, for many of us, the results of NSABP B-51 aren't a huge surprise because they were presented as an abstract at the 2023 San Antonio Breast Cancer Symposium. Nevertheless, can you briefly go over the major findings of NSABP B-51 or RTOG 1304, and what is new being published, if anything, in the New England Journal of Medicine today that we didn't know from the 2023 presentation?
So the NSABP B-51 RTOG 1304 study essentially recruited patients that presented with we'll call T1 to T3, in other words, tumors even from like 2 to 5 centimeters or even 5 centimeters or more, and with positive nodes in the axilla, or we call N1. In other words, the nodes were palpable and positive, but they were not matted, they were not joined together, which would be an N2 disease. So it was T1 to T3 and 0 patients that presented with a biopsy-proven involvement of the axilla. In other words, the nodes were enlarged, there was a needle biopsy made, and the node was deemed to be positive, diagnosed as positive. And then they received neoadjuvant chemotherapy, could be for any subtype. And after neoadjuvant chemotherapy, they went to surgery and they had assessment. They did breast surgery as well as axillary surgery. Axillary surgery could be axillary dissection, could be sentinel lymph node biopsy or sentinel lymph node biopsy followed by axillary dissection. We left that at the discretion of the investigator, but they had to have at least 2 sentinel nodes removed. And then if all these nodes were negative, then the patient was eligible to be randomized in the study. And the randomization in the study was to receive, as we call it, regional nodal irradiation or not to receive regional nodal irradiation. Now, one nuance is that for patients that had breast conserving surgery, lumpectomy, then the randomization was between breast radiotherapy only or breast plus regional nodal radiotherapy in the group that was the regional radiation group. But for mastectomy patients, the randomization was between nothing. They did not get post-mastectomy chest wall radiotherapy or regional radiotherapy in the one group, and in the other group, they got post-mastectomy radiotherapy as well as regional radiotherapy. And a total of about 1,600 patients were recruited into the study for different subtypes. Of course, because the response rates were higher for triple negative and HER2 positive patients, the majority of the patients, about 75% or so, were either triple negative or HER2 positive, but there was about a 20-some% representation of the hormone receptor positive HER2 negative patients. And we allowed to have residual disease in the breast or not, because some patients had total pathological complete response in the breast and lymph nodes, but some patients entered because the lymph nodes became negative, but there was still some residual disease in the breast. About 78% of the patients in the study had total PCR. In other words, pathological complete response. No disease in the breast, no disease in the nodes. The primary endpoint of the study was invasive breast cancer recurrence-free survival. So essentially, it's freedom from breast cancer recurrence or death from breast cancer. That was the primary endpoint. And there were several secondary endpoints: disease-free survival, distant recurrence-free survival, locoregional recurrence-free survival, and overall survival. And the study essentially looked to have 172 primary endpoint events before it would be analyzed. That was one of the potential analyses that would perform. But there was a secondary analysis that was planned for 10 years after the first patient went on study. So we have 2 ways of analyzing the study. Either we got to 170, I think it was 178 events, or 10 years after the first patient. When we reached the 10 years after the first patient were recruited into the study, we did not have 178 events. In fact, we had less. We had 109 events. But because of the time-dependent analysis that was pre-planned in the protocol, we analyzed the study at that point, and we reported the results in San Antonio.
If I could have you clarify quickly, when you refer to an event, what exactly are you referring to for our audience members out there who might not understand, the biostatistics of this?
Right. So essentially, an event of the primary endpoint was the invasive breast cancer recurrence-free survival, which means essentially the patient suffered a recurrence of the tumor, either in the local site, regional site, or distant site, meaning like in the breast or the axilla or somewhere else in the body, like in the bone or lung or liver, or what we call a metastasis. Or if the patient died from breast cancer. These are the sort of events that we call into the primary endpoint. So what we found, the results show that there was no significant difference in the event rates for the primary endpoint between the patients that received the regional radiotherapy and those that did not. Now, the absolute difference was essentially less than 1%. There was no statistically significant difference. And interestingly, both groups did better than we expected because we did not even reach the pre-planned number of events. So this study, essentially, because of the newer treatments and perhaps some selection of patients put into the study, the event rate was lower than we expected. But there was no significant difference in the primary endpoint. There was no significant difference in any of the secondary endpoints. Essentially, all the disease-free survival, distant recurrence-free survival curves, locoregional recurrence-free survival curves almost practically are superimposable. It's less than 1% difference, and none of it is statistically significant. Of course, the conclusion from this was that conversion of patients with positive nodes to negative nodes and then not treating the patients with regional node radiotherapy appears to be oncologically safe based on the results of this trial. And we presented the data in San Antonio in 2023, and the data will be published in the New England Journal. And there is not much difference in the data that will show up in the New England Journal paper versus the San Antonio presentation. There was a little bit of tweaking in the locoregional recurrence-free survival, and that was because we also counted non-invasive events for that particular endpoint, and there were a couple of patients in the radiation group that had an event. Essentially, the numbers became a little bit better in terms of not having any difference between the two for this endpoint. But every other endpoint, the results are exactly the same as they were in San Antonio. Obviously, we still have a little bit more follow-up now in the study, and we'll be doing follow-up analysis as the events accrue, particularly when we get to the 178 events, which is how the study was powered based on an event-driven analysis. But as I said, at San Antonio and the New England Journal will present this time-driven analysis, which essentially allowed us to analyze the study 10 years after accrual of the first patient. The first patient was accrued to the study in 2013, and in 2023, we reached the 10-year mark.
So, one of the goals of this podcast is to help demystify cancer research for the public. As you just mentioned, it's been over a decade since NSABP B-51 was activated in 2013. Can you speak a little bit about the logistics of conducting a massive trial like this and why it sometimes takes so long to get to the finish line? And what also was happening behind the scenes in the last 2 years between the initial presentation of B-51 at the 2023 San Antonio conference and the publication in the New England Journal of Medicine today?
These large prospective randomized trials take a long time sometimes to conceive and create the whole study and the protocol and activate the study in multiple sites through a cooperative group, and takes a long time also to accrue patients. Some studies accrue faster and some studies accrue slower. The B-51 RTOG 1304 was a study that accrued patients slowly. In fact, in the beginning of the study, we had very slow accrual. At points, we considered that maybe the study would not be feasible because it was a very important paradigm change in study. And of course, radiotherapists and other oncologists were entranced to the concept of giving radiotherapy for patients with positive nodes. It's very difficult sometimes to change something that's been established for many years and benefits patients. In fact, doing what we call a de-escalation trial. We de-escalated radiotherapy in this trial. But with time, we persevered and we did a lot of publicizing the study, presenting in meetings, talking to investigators. And at some point, sort of the accrual started to increase. And they were able eventually to complete the study in a total accrual of 7 years. The accrual finished in 2020. But as I've said before, some of the more impactful studies are always the ones that actually have a difficulty accruing because you're changing a very well-held gestalt in how we treat patients. Comparing, let's say, in another study, 2 chemotherapy regimens, but tweaking or adding a drug, it's much easier because it's more acceptable to the patient and to the physician that accrues the patient on the study. So this is not new. It happened with, for example, the studies of lumpectomy versus mastectomy that took years to complete. It took time to do the omission of axillary dissection studies for patients with positive sentinel nodes when sentinel node became a standard. So it's not unusual to see that. But I think the rewarding part of all this is that persevering and doing a study like this potentially can save a lot of patients' use of radiotherapy when they don't get any benefit. Obviously, we want to give it for patients that get benefit. And that was sort of again, what everybody believed at the time, but we needed to do that. And we had the rationale. It took some time to build up the rationale for the study so it will be acceptable to both patients and investigators to have some data to say, well, we see that if you have a pathological complete response, your local recurrence rate will be lower. And if your local recurrence is lower, almost as low as a non-negative patient, potentially you may not benefit from radiation, even if your nodes were positive before. So it's a very important effort. It requires a lot of coordination and cooperation in the cooperative groups and a lot of support from the NCI and all the investigators that actually put patients on the study. What happened after the presentation until the publication, and it takes some time to get everything together with the paper, to edit the paper, to have all the co-authors, sign off on the paper, and then eventually submit it to the journal, get the revisions, and so on and so forth. But we're very happy that this actually now comes to fruition, and hopefully it will resonate both with physicians and patients, and lead to a very judicious, as I call it, judicious de-escalation of radiotherapy for patients that actually meet the criteria for the study and have tumors as we had in the study.
Again, just amazing work on the part of the NRG Oncology Breast Cancer Core Committee that I want to congratulate you for and for your leadership. I wanted to actually ask you something that I've been hearing through the grapevine. I've heard that a practical concern about B-51 from radiation oncologists out there, well, they are satisfied with the results of B-51 for the more aggressive triple negative and HER2 positive breast cancers. They're concerned that there might not yet be enough follow-up to draw the same conclusions for estrogen receptor positive tumors, given that they are slower growing and can sometimes unexpectedly come back even decades later because they're so much slower growing. What are your thoughts on the applicability of B-51 to estrogen receptor positive tumors, given that the time horizon for recurrence might be much longer than other types of breast cancers, and that there might not yet be enough follow-up in B-51 to draw conclusions about estrogen receptor positive tumors?
Yes, that's a very important question. And I would agree with that, and I'll elaborate that in a minute. But overall, the study included different subtypes. So every subtype was represented almost about 20-25% of the patients. In other words, about 20-25% were triple negative, but 20-25% or so were ER positive, HER2 negative, and about 50% were HER2 positive, split between the hormone receptor negative HER2 positive and triple positive, hormone receptor positive, HER2 positive. So every subtype is represented almost to about a quarter of the total study population. When we looked at the benefit of radiotherapy according to different factors, because that's typically what you do in these studies, you look at it according to age of the patient, lumpectomy or mastectomy as treatment in the breast, sentinel lymph node biopsy or axillary dissection in the axilla, and so on and so forth, different and subtype. When we looked at it according to all the stratification factors, as we call them, for the trial, in other words, when we stratify to make sure that these factors that potentially could be prognostic are equally represented between the two groups, we found no interaction of the treatment effect according to all the stratification factors that we used in the trial. We also did an exploratory analysis looking at the age of the patient, the type of axillary surgery, and also the tumor subtype. And we did not find any interaction according to age. We didn't find any interaction according to axillary surgery, but we did find a significant interaction between tumor subtype and outcomes. And what we mean by that is that the effect of radiotherapy was different in different subtypes. And what we found essentially was that triple negative patients, the ones that typically would recur early on in the course of the disease, in fact, those patients did not benefit from radiotherapy. And if anything, there were more events in the radiotherapy group than in the non-radiotherapy group. We can explain what is that, and it could be just by chance, because when you break down these groups into a quarter of the total trial population, you may see some difference that may be a statistical sort of aberration and not necessarily a meaningful difference. Nevertheless, for these patients, we feel very comfortable to say that the radiotherapy benefit is not there, because those patients typically would recur within the first 5 years. And we have at least 5 years of follow-up in the study, and minimum follow-up was 3 years. So we don't expect that these results would change much with additional follow-up. HER2 positive patients were kind of in the middle. They didn't seem to have much benefit one way or the other. So I think we're comfortable with those as well. But the group of the ER positive HER2 negative patients appear to have some benefit from radiotherapy. There was a 40% less risk of an event if you had radiotherapy versus if you did not. Therefore, for those patients also, because they have a more prolonged recurrence period, they have recurrences sometimes 5, 10, 15 years later, we still need more follow-up to start getting more comfortable with the results of the study, because again, they represent only a subset of the patients. So for those patients, we acknowledge that we still need more follow-up, and in general, we need more follow-up on the study in general, because some of the previous studies of radiotherapy have shown that the benefits of radiotherapy in reducing distant recurrence and overall survival may accumulate later on in the course of the disease. Of course, this was studied with upfront surgery and then radiotherapy. Whether this would be applicable in this case setting of neoadjuvant chemotherapy remains to be seen, but we still, remain somewhat cautious about the ER positive HER2 negative patients, and we're still going to wait for more follow-up.
Thinking along those same lines, in the 2 years since B-51 was initially presented at the San Antonio Breast Conference, and people have had time to digest and discuss the findings, have you heard any other criticisms or take-homes that you thought were maybe a little unexpected about the study that you'd like to address?
Well, one question that was raised when we presented the study and was discussed in San Antonio was whether in that study we had patients with what we call isolated tumor cells. And this is a category of somewhat nodal involvement that doesn't meet the staging criteria for involvement. It's not N1 disease, it's still N0, but there could be, by immunohistochemistry, some isolated tumor cells in the nodes. And the answer to that question is that we just don't know how many of these patients may be in the study. We expect them to be a low number, probably not more than 2 to 3 or 4%, based on other studies on the prevalence of these isolated tumor cells after preoperative chemotherapy. But simply we don't know because we didn't ask at the time of enrollment, because those patients were considered non-negative. So it's possible that we have these patients in the study, but we have to go and do a manual review of the pathology reports to identify. And of course, we'll do that and report at some point. I don't think it's going to be very meaningfully changing the results of the study, but that was one of the concerns. And of course, the other one was what we discussed before, is that longer follow-up, particularly for some of the subtypes like ER positive HER2 negative, would be more important to see when in this subtype, are there any more recurrences accumulate differentially in one group versus another? And we'll follow up on that.
Dr. Mamounos, I want to thank you again for joining us. Before we let you go, we recognize that this has been a major team effort by the NRG Oncology Breast Cancer Core Committee, and this has been the culmination of over a decade of work. I wanted to give you a chance before you go to recognize any of the key players on the team that made B-51 a success, and really anyone out there who you feel deserves recognition for this, I think, unmitigated success.
Well, certainly this was a tremendous effort, and in fact started by two different groups, the NSABP and the RTOG. The RTOG has been a partner in this study. We developed it from the beginning with the rationale and started it. And then, of course, our groups merged. So now we are NRG Oncology. And of course, I want to acknowledge the co-PI Julia White, which is also the first co-author in the paper, who was the chair of RTOG Breast Committee at the time. And now she's a vice chair for the NRG Oncology Breast Committee, who has done a tremendous work in this study. Other investigators from other institutions like Tom Buckles from MD Anderson that had published papers that led to strengthening the rationale for the study. A big, of course, contribution to the statistician in this study, Hannah Bandos, which did multiple analysis and have ushered this study for many, many years. Tom Julian, who is the protocol officer of the study at the NSABP headquarters, also a long-standing supporter and contributed majorly to the study. And of course, all of the principal investigators who really jumped on this study eventually and accrued patients in the study and making it a success, because there have been previous studies that actually did not complete accrual and did not give us an answer when we tried to omit radiotherapy. And of course, all the operations and the biostatistical center personnel that really contributed to conducting the study on a day-to-day basis. last but not least, the more important components of this, the patients who participated in the study and taking a chance whether not receiving radiotherapy, may increase their recurrence, or maybe trying to benefit from that, because obviously radiotherapy has also some adverse effects, particularly like in patients that have mastectomy and have reconstruction. So there's something to gain, of course, but there's also something to lose by taking this treatment. So these courageous patients, I think, allowed us to complete the study, and we're really indebted to those patients for putting themselves and their health and their life on the line to participate in the study. So we truly appreciate their contribution, and many more women in the future will benefit from their contribution.
Our next guest today is Dr. Julia White, who is the radiation oncology co-principal investigator of NSABP B-51 and co-chair of the NRG-Oncology Breast Cancer Core Committee. Dr. White is a radiation oncologist specializing in breast cancer at the University of Kansas and member of the National Cancer Institute Breast Cancer Steering Committee.
Prior to the culmination of NRG Oncology, Dr. White was the chair of the Breast Cancer Core Committee for RTOG, where the NSABP B-51 trial was first conceived as RTOG 1304. Dr. White, congratulations again on the publication of NSABP B-51 or RTOG 1304 in the New England Journal of Medicine. We've just heard from Dr. Mamounis about the details and logistics of B-51, but I'm wondering if you could put this into a much broader perspective. As you know, it is exceedingly rare for a study about radiation dose or technique to get published in the New England Journal of Medicine. Why is NSABP B-51 such an important paradigm-changing study, and how did it get into the New England Journal of Medicine?
The important part about this trial and its impact is while it does reflect a change in radiation practice, it also confirms the importance of pathologic complete response in the treatment of breast cancer as being very prognostic and predictive of outcome. We know that there has been increasingly attention on using pathologic complete response in breast cancer and other disease sites as actually an endpoint. In and of itself. So the question has always been, what does pathologic complete response mean for breast cancer patients? And can you apply it broadly across all breast cancer subtypes? Because not all breast cancer is the same. It doesn't behave the same biologically. So I think it was a combination of this expanded meaning and impact, clinical impact of pathologic complete response, changing the course of treatment and still coming out with excellent outcomes. And also being able to answer the question of when do you not need radiation because you have such a great outcome based on chemotherapy or a systemic therapy response.
In that vein, can you speak to the patients out there whom the results of B-51 will impact? How will their treatment and experience be different and perhaps better because of B-51?
Well, I think up to now, whenever we saw as radiation oncologists, whether there was a positive lymph node, there has been a significant amount of past clinical research done that for a positive lymph node in the armpit or the axilla at breast cancer diagnosis, it becomes important that we add radiation after you finish your surgery and your chemotherapy, whichever comes first, that we add radiation to where the native breast used to be, or the native breast, if it's intact, and the regional lymph nodes, not only the armpit lymph nodes or the axillary lymph nodes, but the lymph nodes on the internal side of on the other side of the breast, adjacent to the breastbone or sternum. And then these lymph nodes in the armpit also feed up to the lymph nodes in the base of the neck. We knew that when we add radiation, when surgery is the first line of therapy and systemic therapy is the second, and radiation comes in, we know when we add radiation, we reduce the risk of all recurrences, local, regional, and distant metastases, and you see an improved breast cancer-specific survival. So we want every patient to have as much access to survival as possible. So we have always radiated patients when they present with positive lymph nodes, whether they got got chemotherapy first or whether they got their surgery first. And that had been standard of care. And we thought we were doing an excellent job doing that. Now, what we've understood along the way is when you start with your systemic therapy first, meaning your chemo or your anti-HER2, when you have anti-HER2 breast cancer, or immunotherapy in the setting of triple negative cancer together with chemo, when you give the appropriate drug therapy up front, and at the time of surgery, there's no cancer left in the lymph nodes or in the breast. The question has always been is, do the same rules apply? Do we keep on giving you the radiation just as we did when they were positive before you had the drug therapy? And I think the good news about B-51 1304 is that it really demonstrated that the pathologic complete response, meaning there's no cancer cells in the lymph node, no cancer cells in the breast, of which 80% of our population had complete pathologic response, that you do really well, really, really well. And the radiation, you don't need the radiation. The outcome is the same. So it's really good news. And it, again, highlights the importance of when you get drug therapy up front, that if you get a great response in the breast and in the lymph nodes, if they were positive, it tells us a lot about what's going to happen with the cancer in the future and allows us to omit some treatments that don't necessarily are not going to add anything.
Now, I am admittedly not someone who treats a lot of breast cancer, but if I'm reading the results correctly, it seems that a lot of the work that we are doing to get radiation dose into the regional lymph nodes surrounding the breast, say in the supraclavicular region or the lymph nodes near the collarbone, and even those pretty deep in the chest, you talked about the internal mammary or the internal thoracic lymph nodes, isn't necessary anymore if the chemotherapy or targeted therapy or whatever therapy they've had has cleared the cancer from these lymph nodes. Has NSABP 51, am I interpreting this correct, that this has been basically simplified for radiation oncologists out there treating these patients? And for the record, can you just very simply describe what is the new standard of care as a result of NSABP 51 being published in the New England Journal of Medicine today?
To me, I think there's two important messages from this trial. The first message is that if you started off with positive lymph nodes as a breast cancer patient in the axilla, obviously biopsy proven, and you go through the appropriate systemic therapy, chemo, targeted therapy, immunotherapy, and at the time of surgery, those drugs have cleared the cancer of your lymph nodes. And you probably, I mean, 85% of our patients had complete pathologic response in the breast. So I would say they, you have a good response in the breast as well. That the good news is you've completed your local regional therapy. You don't need to add radiation on in that setting. We worked really hard on the B-51 1304 trial to make sure what was done with radiation was well understood, because we wanted to give everyone confidence at the end of the trial that it was known exactly what was radiated and what was not. And so this, to my knowledge, is the first clinical trial, at least in the NCTN and maybe internationally, where we required that the nodal targets, the armpit or axillary lymph nodes, the lymph nodes on the inside of the breast, adjacent to the sternum bone, the internal, we call them internal mammary in breast cancer. Other people call them internal thoracics and other disease sites. That those were targeted specifically, and then the lymph nodes that live at the base of the neck above the clavicle were targeted. That we gave very specific ways the radiation should be done. We gave very specific dose constraints, meaning how do we keep safe the normal tissue organs around those areas we're targeting with radiation. And I have to say, radiation oncologists who entered their patients in trial did a fabulous job. For the most part, 95% of the cases came in meeting all those requests by us for the quality of the radiation. And three radiation oncologists, excellent breast cancer radiation oncologists, Dr. Atif Khan, Simone Shadelman, and Mylan Torres, reviewed every one of those cases and scored them for their quality. And I think for the patients who did get radiation on the other arm, and I would say this applies to patients who still need radiation, meaning their lymph nodes remain positive. The methods we used on B-51 1304 have demonstrated that the toxicity rate was low. So oftentimes when you treat patients, especially if about 40 to 50% of them have had mastectomies, you see grade 3 skin toxicities along the lines of 15%, 20%. In our trial, we using these methodologies for the radiation, we have a dermatitis, skin reactions of a grade 3 of about 5.8%. We yet to have to analyze and publish our quality of life data and what it meant for reconstructions, and that's forthcoming. But we actually think the other message that comes out of it is that careful radiation planning for when we have to treat the lymph nodes is beneficial.
Now, you speak about dermatitis, which is a common side effect of breast cancer radiation. I also wanted to ask about if there were any implications for targeting these regional lymph nodes in terms of lymphedema or swelling. This is something that can be debilitating to patients who have received radiation to the lymphatics that drain the fluid out of their limbs. Were there any findings pertinent to or relevant to regional nodal irradiation in terms of lymphedema?
It will be collected as part of our patient-reported outcome quality of life, and that is forthcoming, that analysis. So the only data we've collected so far, and I have to go back and look at the actual the toxicity reported for lymphedema, but when we compared numerically toxicity from one to the other, there were no significant changes. But in terms of the patient experience, that data is forthcoming, and specifically that will be looked at as well as outcomes when patients with or without radiation who've gotten a reconstruction post-mastectomy. So I think that will be very informative as well.
So now that B-51 has produced very definitively practice-changing findings, what are the next steps and opportunities for this population of patients? Do you think that there are further ways to de-escalate and reduce treatments? What's brewing in the NRG-Oncology Breast Cancer Core Committee and nationally in this space now?
I don't know that I love the word de-escalation because I think what we're doing is giving the right patient the right treatment. So it's not that we're taking things away in terms of cancer therapy. I think we're giving them the right cancer therapy now. If we know their lymph nodes are and were positive and then turn negative with the systemic therapy up front, I think that we're taking away unnecessary treatment. And I think that's a theme we're trying to figure out quite a bit in our breast committee. We have, as you may know, 2 trials looking at omitting breast radiation in selected populations of patients who undergo lumpectomy for breast conservation. And I think we feel pretty confident that you need to use biology to select patients. You just can't say what's the size of the tumor. So the NRG-B007, the Deborah trial, is asking the question that if you have a stage 1 hormone-sensitive, HER2-negative breast cancer between the ages of 50 and 70, and you get a genomic score, an oncotype recurrence score, do you really need the radiation? As we all know, that score helps, 2/3 of women avoid getting chemotherapy anymore. So we're now questioning, can that help us find patients who don't need radiation? And that trial has been accruing well. We also have a trial, NRG-B008, the HERO trial, asking a similar question in patients that have HER2-positive breast cancer. And that's we're very excited about because there is data to say that, again, when you get your chemotherapy first, and there's no cancer left in the breast this is clinically node negative breast cancer, that the recurrence risk should be very low, and maybe radiation to the breast does not add anything. Similarly, if you have a very small HER2 positive breast cancer and you get lumpectomy first and then your systemic therapy, does a similar approach apply? So in that case, either getting the HER2 therapy with chemotherapy up front or after, patients can go on that trial. And then finally, I think in a hormone-sensitive, HER2-negative young women with moderate risk breast cancer, they have either a tumor that has a high genomic score, saying that they're at higher risk for distant metastasis or cancer spreading elsewhere in their body, or they have positive lymph nodes. There's a large trial being run that we are very excited about, and that's NRG-B-009, the offset trial. And in that trial, we're asking the question, do these younger women, do they really need chemotherapy? Can we just do ovarian suppression with appropriate anti-hormone therapy or endocrine therapy, and let these women also avoid the side effects and toxicities of chemotherapy? So we feel making sure we're giving the right treatment to the right patient has been a central theme of our breast cancer core committee.
Dr. White, congratulations to you and Dr. Malmunas again. And I wanted to really thank you for joining us on the NRG Oncology podcast today and making all of the findings of NSABP B-51 so crystal clear to us and our audience.
Thank you for having us.
For those of you who haven't subscribed or followed us yet, remember to follow us on Apple, Spotify, or YouTube. And if there's something you want us to cover, write to us on the NRG Oncology podcast homepage. The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily reflect the official views of the National Institutes of Health. Thanks, everyone, for tuning in, and happy clinical trials.